Hello everyone, welcome back to the series of lectures in neurology. So in our discussion on stroke, today we will be continuing with this new chapter which is management of stroke. So let's begin. So whenever we speak about CVA or stroke, there are a set of investigations that we have to perform. So the first investigation that we have to do in the diagnosis of stroke is a plain CT brain. So it is a plain CT brain. And what is the reason for this? Because the first step in identifying a stroke is identifying whether this is ischemic or hemorrhagic in nature. Okay. So a plain CT is done to rule out hemorrhagic stroke. Because the management for a hemorrhagic stroke is completely different from that of a thrombotic stroke. Then in the plain CT, if there is a thrombus, there is a specific sign that you should be aware of. So whenever you do a plain CT and if there is a thrombus in the MCA, you get something called as the dense MCA sign. So when you take the coronal section, this is your MCA and you find a bright spot within the MCA territory, and this is what we call as the dense MCA sign, which is one of the identifying signs on the plain CT. The next investigation that we have to do in the management of stroke is your MRI and MRA. Right? So MRI is your magnetic resonance imaging and MRA, where A stands for your angiography, which basically helps in capturing the vessel status. So your MRI plus MRA is your gold standard in the diagnosis of stroke, which helps in identifying not only where the ischemia is, it also helps in identifying what is the condition of the vessels. Right? And we also have variants of MRI where you can find out which part of the brain is salvageable, which part of the brain is not, and visit within the window period for thrombolysis as well. So first, when you get an MRI of the brain, you should understand that there are multiple sequences. We do not have to know every sequence, but let us just understand two sequences first, which is your DWI sequence and your ADC sequence. Your DWI stands for diffusion weighted imaging. Okay, so you have two sequences, which is your DWI and your ADC sequence. So what are the things that you have to see in your DWI and ADC sequence? So your DWI basically shows a hyper intense lesion in an acute stroke. So can you see here, you are seeing hyper intense lesion in your acute stroke. Then in an ADC sequence, how will an acute stroke appear? An ADC sequence remains hypo-intense for 24 hours. So acute stroke within 24 hours. Within 24 hours is hypo-intense in your ADC and it is hyper-intense in your DWI. Okay. So your DWI and ADC helps in confirming that this is an acute stroke. The next image that you will have to see is what is called as your flare image. Now as I showed you in this picture, this is a stroke of your right occipital territory, right? So this is a stroke of your right posterior, probably a PCA circulation stroke. Your occipital, your temporo-occipital region is involved. Now, when you see the flare sequence, if it is hypo-intense, then this means that this is an acute stroke and it is within the window period. So if the DWI is hyper-intense, your ADC is hypo-intense, and your flare is also hypo-intense, then this patient can be a probable candidate for thrombolysis. Okay, if it is hyper-intense, if it is not hypo-intense, or if it becomes as white as it is in DWI, that means that it has crossed the period of thrombolysis, the patient cannot be taken up for thrombolysis. Right, so here can you see that the DWI is hyper-intense, flare sequence is hypo-intense, so the patient is still in the window period. So this is how your MRI images are going to help you understand whether the patient is an acute stroke, is it a thrombotic stroke, and if he can be taken up for thrombolysis or not. Then can you see here, this is your 3D TOF. TOF stands for time of flight. So 3D TOF is basically used to image your vessels. And can you see that in the left side your MCA is intact, but your right side your MCA is cut off. This is your right MCA cut off. Can you see that there is no MCA further, right? So this can be used to image. Okay, so similarly here the MCA is missing. So this is the basic aim of your MRI and MRA TOF, right? Because when you do an invasive angiography, you will have to put a contrast, wait for the contrast, so on and so forth. So TOF images gives us very rapid results. Alright, fine. So this is about your diffusion ADC flare mismatch, which aids in the diagnosis of acute stroke. So whenever a patient comes to you, first do a CT, rule out hemorrhagic stroke, and then do your MRI and find out which stage of evolution is the stroke in. Okay. Then a specific type of MRI that we use is a perfusion weighted MRI. So what is the difference between a diffusion and a perfusion weighted MRI is that the perfusion weighted MRI basically is a type of MRI which determines the different images based on the cerebral blood flow, and it helps in assessing the vascularity of the lesion. It helps in assessing the vascularity of the lesion. So the images are generated based on the cerebral blood flow. So it depends upon the cerebral blood volume, which is CBV. CBF is your cerebral blood flow. Cerebral blood flow. And it depends upon MTT. MTT means mean transit time, the time taken for the blood to flow from one point to another, which is that mean transit time, and the time to peak, So these are the various parameters which are basically determined in your perfusion weighted MRI. So what is the use of this perfusion weighted MRI? So whenever you do a perfusion weighted study, we can find out about one important area which is called as the penumbra, So now in this patient, the stroke is here. Okay, so in your diffusion weighted MRI, you have already found out what is the stroke. But there is a region of decreased cerebral blood flow, because whenever there is ischemia, it has not yet gone into infarction, there is ischemia, there is decreased cerebral blood flow, there is a region of ischemia which surrounds the infarct. So it helps in identifying the area of ischemia where there is decreased blood flow but the blood flow has not completely stopped, and this region is what we call as the penumbra. So what is the use of identifying the penumbra? The use of identifying the penumbra is that this region is salvageable. It has not yet undergone an infarct. So if you restore the blood flow through any method, be it thrombolysis, be it thrombectomy, then that area can be salvaged. So the penumbra, identification of the penumbra is very important, because we will know which part of the stroke is still salvageable. Okay, right? So what we do is a diffusion-perfusion mismatch. Okay, so let us understand this diffusion-perfusion mismatch. So this is your DWI sequence, and this is occurring hyper-intense on a DWI sequence. But when you do a perfusion weighted image, you will know that only this much is the core infarct, but this is actually the penumbra. So you will know the actual area which can be salvaged, and this is your diffusion-perfusion mismatch which can be used for identifying the penumbra. Okay, fine. So this is about the various methods and usage of MRI in the diagnosis of stroke. So we saw here, this is your diffusion ADC flare mismatch which is used in the diagnosis of acute stroke, and here you have your diffusion perfusion mismatch which is used to find out the penumbra and which part of it can be salvaged. Okay, let us understand how do you approach a patient who presents to you with a suspected CVA. So a suspected acute stroke, in the pre-hospital call, you do something called as a code stroke activation, right? You do a thorough history examination, and if you're able to find out when the stroke has happened, it's well and good. Okay, in many a times you will not be able to find out whether the stroke is less than 6 hours or no, right? Because thrombolysis has to be done within a specific window. It is 4.5 hours, right? So only then the patient is suitable for thrombolysis. So that is the reason why this is important. So if the onset is less than 6 hours and the CT brain is not showing any hemorrhage, then the patient can go for thrombolysis if he is eligible for thrombolysis. IV PA is tissue plasminogen activator, so he can undergo thrombolysis. If the onset is more than 6 hours, okay, so if it is between 6 to 24 hours and the CT is not showing any hemorrhage, then he can do a thrombectomy. If there is a favorable perfusion and if there is an ICA or a M1, M2 infarct or a basilar artery infarct, that means large vessel infarction, then he can go for a thrombectomy. Okay, fine. So you need not always have an MRI for the diagnosis of stroke. Diagnosis of stroke can be brought about with the CT as well. It's only when you're going to go ahead and do invasive procedures like a thrombectomy where you will mechanically remove the clot. Then this you need a imaging of the vessels. Right, so if there is a large vessel stroke, ICA stroke, MCA stroke, you can remove the clot via thrombectomy, and if it is between 6 to 24 hours. So thrombectomy can be done up to 24 hours. Thrombolysis has to be done less than 4.5 hours. Okay, ideally 4.5 hours. So this is about how you will approach someone who presents with symptoms similar to stroke. Okay, so thrombolysis means that we've understood in the basics of approach to stroke class that a thrombus is formed. A thrombus is formed based on your lipid plaque, then there are platelets, then there is fibrin, and finally there is occlusion. Right, so similar to how you thrombolyze an MI where there is occlusion of the coronary arteries, here you can thrombolyze a stroke as well, and an ideal thrombolysis should be done less than 4.5 hours. An endovascular intervention or your thrombectomy can be done from 12 to 24 hours. Clear? Now let us look at thrombolysis a little bit more in detail. So what are the drugs used for thrombolysis? Okay, so the most commonly used and the recommended drug is your RTPA, which is altiplase. Okay, recently in the year 2025, after nearly 30 years of no other drug being approved, the newest drug which is approved for thrombolysis in stroke, we are not talking about thrombolysis in MI, it is stroke. Here it is tenecteplase, which is the newest drug which is approved for thrombolysis in stroke. Okay, so how is it administered? It is administered IV. So in an acute ischemic stroke less than 4.5 hours, we do thrombolysis. So what are the indications for thrombolysis? So the indications are there is a clinical diagnosis of stroke and it has to be an ischemic stroke. We are not going to thrombolyze a hemorrhagic stroke, right? Because it's a bleed. The main aim of a thrombolysis is that it's going to break the clot. If there is no clot, you will not thrombolyze, and if it is a bleed, you are definitely not going to thrombolyze. So it's only in an acute ischemic stroke. So there is a clinical diagnosis of stroke and onset of symptoms to the time of drug administration is less than 4.5 hours. So very importantly, you have to rule out hemorrhage by a CT scan before you take up any patient for thrombolysis, and there is no edema or more than 1/3 of the MCA territory involvement. That means thrombolysis cannot be done in large strokes or if there is a complete MCA occlusion, the entire MCA territory is gone, then the patient has high chances of cerebral edema. In these kind of patients, you do not undertake a thrombolysis. Okay, so strokes have to be involving less than 1/3 MCA territory. Okay, so less than 1/3 MCA territory infarct, and the age is more than 18 years of age. So this is about the various indications for administration of your thrombolytic agent. What are the contraindications? The contraindications are more important. So the first and the most important is your sustained blood pressure more than 185/110. The cutoff is 185/110. So if the blood pressure is more than 185/110, then despite treatment. So if a patient is presenting to you with stroke, like I told you in the beginning itself, so there will be a physiological response to maintain the cerebral blood flow. The blood pressure will also be increased. But if you are taking up a patient for thrombolysis, the blood pressure cannot be more than 185/110, because once you give the thrombolytic agent, there is a high risk of bleed, and hence the BP has to be controlled. So the BP has to be brought down below 185/110. So if the BP remains to be more than 185/110 despite treatment, then it is a contraindication to thrombolysis. Okay. So how much should you bring down the blood pressure? Bring down the blood pressure by not more than 10%, because what happens when you bring down the blood pressure too much, then whatever penumbra region is also left out, then that can also go into infarction because of decreased blood, right? Because the penumbra is highly dependent upon the cerebral blood flow. Okay, fine. Then the next absolute contraindication is bleeding diastasis, where the INR is more than 1.7 or the platelet counts is less than 1 lakh. So INR more than 1.7 or platelet count less than 1 lakh. Apart from that, absolute contraindications, presence of infective endocarditis or presence of aortic dissection, concomitantly do not thrombolyze the patient because there are high chances of bleeding and collapse. History of recent head injury or intracerebral hemorrhage. Then patient has been on NOAC or unfractionated heparin, because these are already anticoagulants. If you thrombolize, there is a high risk of bleeding. Then major surgeries in the past 14 days. Then gastrointestinal bleeding in the past 3 weeks. Past stroke or trauma less than 3 months. And a recent MI. Recent MI has been removed from the latest thrombolysis guidelines. What is there is your GI surgery past 3 weeks and any other major surgery in the past 2 weeks, any neurosurgical procedure in the past 3 months, past stroke or trauma in the past 3 months. Okay, so these are about the various absolute contraindications for your thrombolysis. So whenever a patient presents to you with stroke, if you are intending to thrombolyze a patient with your altiplace, always in your emergency departments there is a list what we call as your thrombolysis checklist. So you put on ticking a tick mark and see if all the checklist items are met, and then only go ahead and do a thrombolysis. Okay, fine. Now, how do you administer your RTPA, which is your tissue plasminogen activator or altiplase? So you require an IV access with 2 peripheral IV lines, and then you administer 0.9, the dose is 0.9 mg per kg IV, 10% of which is given as a bolus dose and the rest of it is given as an infusion. So 0.9 mg per kg is the dose of altiplase and you give it 10% as bolus and the rest of it you give it as an infusion, and then this is given over 1 hour, right? And you ensure that no other antithrombotic therapy is given in the next 24 hours. Now, what are the things that you have to monitor whenever you give RTPA? Now, because this is a thrombolytic agent, you have to ensure that the patient's blood pressure is being monitored carefully. Secondly, because this is a thrombolytic agent, there is an increased chance of bleeding into the cerebral cavity, right? So there is an increased chance of bleeding within the brain when you are attempting to do a thrombolysis. So always remember that this risk is always there. So whenever there is a decline in the neurological status or uncontrolled blood pressure during your thrombolysis, then you will have to stop. You will have to stop the thrombolysis and immediately take up for a CT brain, right? So during your thrombolysis, if the patient's neurological status is declining, then remember that this could be a bleed. Urgently take up for a CT brain. And how do you reverse your thrombolysis? You can give FFP. So arrange for this FFP and start transfusing. Okay, so cryo and FFP are those which are given in the management of your thrombolysis induced bleeding. Then you avoid urethral catheterization for more than 2 hours after your thrombolysis. Another very important side effect while giving your thrombolytic agent, they can develop an allergic reaction or an anaphylaxis, right? So if they develop shock, hypotension, they start developing breathing difficulties, then think of an anaphylactic reaction. So for anaphylactic reaction, we can give antihistamines and glucocorticoids, a newer drug which is your bradykinin inhibitor. Icatibant. Newer drug which is your bradykinin inhibitor is your icatibant, which can be given if they develop an anaphylactic reaction to your RT. Okay, so this is about thrombolysis in stroke. So we have understood what are the indications. Indications are acute ischemic stroke less than 4.5 hours, which does not involve more than 1/3 surgery of the MCA, and there is no evidence of hemorrhage. You take them up for thrombolysis. Always remember the list of contraindications and the complications that can arise during the same. Now, what are the medical support that you have to give when a patient presents with stroke? Like I told you, the blood pressure has to be maintained less than 185 by 110 millimeters of mercury, and you can give them even IV injections to bring down the blood pressure. If there is a stroke with a myocardial infarction, you have to maintain the perfusion. Then only because the perfusion has to be maintained, you can administer a beta blocker. Target blood glucose less than 180 mg per deciliter. Give your IV lines or your catheterization, especially if you are doing a bladder catheterization, before the thrombolysis, not after the thrombolysis, because there is a risk of bleeding from any of the sites, be it your IV sites or your catheter. So you don't do invasive procedures for at least up to 3 to 4 hours or up to 24 hours. Then DVT prevention, again you do not give heparin because just now you have thrombolized the patient, so you give pneumatic stockings. And always remember that there is a high risk of cerebral edema, especially if there are large territory strokes that are involved, right? So this peaks on the 2nd to 3rd day and it goes up to 10 days. So a patient presenting with ischemic stroke by 2nd to 3rd day or up to 10 days sudden deterioration in your neurological decline, always consider cerebral edema. Which circulation strokes are more prone to cerebral edema? The posterior circulation strokes. Posterior fossa strokes are more prone to cerebral edema. If it is anterior circulation, it is more so if the infarct involves more than 1/3 MCA territory. Okay, so they can present with a decline in the neurological status, they can present with stupor, they can present with inequality of the pupils. Okay, and isochoria. They can present with an isochoria. So how do you manage this? You will have to give anti-edema measures like mannitol or 3% NaCl. Okay, if there is no improvement in the symptoms, despite that the patient may have to go for an emergency craniotomy. They may have to go for an emergency craniotomy because as the pressure builds up, the cranial cavity is a closed space, right? Then it can lead to herniation of the structures and hence you will have to relieve the pressure. You will have to do a craniotomy, remove a part of the bones and do an emergency craniotomy so that the pressure drops. Okay, fine. Now, if the patient is not eligible for thrombolysis, then what can be done? Either you go ahead with medical management or you can see if you can do an endovascular therapy. Okay, so what do you do for medical management? So what do you do for medical management? You give antiplatelet aspirin, which is given as 150 mg loading dose and along with a high intensity statin, and you continue the same lifelong. So you give aspirin 150 mg loading dose and you continue the same as aspirin with high intensity statin like your atorvastatin 40 mg. Okay, so we give single antiplatelet and statin as your part of your medical management. So, but whenever there is a situation where the patient cannot undergo thrombolysis due to multiple reasons because of any of the contraindications or he has not come in within the window period, then his weakness or whatever kind of neurological deficit that he has, most of the time if it is a thrombotic stroke, it remains permanent, right? So, whatever antiplatelets that we are going to give is not going to break down the clot, rather it is going to prevent another stroke. So, it is going to prevent another episode of stroke. So, whatever neurological deficits that he has, for that he may have to undergo rehabilitation. He may have to undergo rehabilitation for the same and to see whether any of these neurological deficits are going to improve. So, when do we give dual antiplatelet? Dual antiplatelets are given if there is a transient ischemic attack, right? Or if they are given in small strokes. They are given in small strokes or for example your lacunar strokes. Right? So, that is when you give dual antiplatelet therapy, which includes aspirin and clopidogrel. Fine. Now, let us understand endovascular therapy in stroke. Endovascular therapy means that you are going ahead and removing the thrombus using interventional radiology. Okay, so you could do interventional procedures to remove the thrombus, which is a thrombectomy. Okay, so when can you do an endovascular therapy? You can do it only for large vessels. You cannot go into small vessels and remove the stroke, right? So, which are the large vessels where you can do endovascular therapy? Internal carotid artery, basilar artery, MCA. So, ICA, MCA or basilar circulation you can do endovascular therapy. Okay, fine. So, here you can do a thrombectomy. You can do a thrombectomy where if there is a vessel like this and the clot is here, you put a snare or you put a device and you go and remove the clot and bring the clot out. Okay. So, this is your mechanical thrombectomy, or in certain situations you can even put a stent where if there is a thrombus that the space will be formed and can restore the circulation, and the travo stent. The travo stent is the most common stenting procedure which is being done recently. This is very similar to how you treat your MI. Okay. So, mechanical thrombectomy is done for a proximal thrombus If the thrombus is proximal, you try and remove the thrombus. If there is a distal thrombus, it's very difficult to do a mechanical thrombectomy, then you can put a stent. Okay, fine. So how do we do it? We put a guide wire. After the imaging, you find where the clot is, you put a guide wire, and through this itself you wire in a stent and you put in the stent. Okay, fine. Then what is ICAD? ICAD is intracranial atherosclerotic disease. Right, so intracranial atherosclerotic disease, for example, small vessels or very small branches of the MCA or PCA or ACA, in these kind of strokes, intracranial atherosclerotic disease, you cannot do a thrombectomy and you have to do a medical management. Okay, clear? Fine. Now let us look at embolic strokes. So whenever we speak about embolic strokes, I told you any form of arrhythmias are the most common cause for a cardioembolic stroke. Right? So when we speak about arrhythmias, which arrhythmia comes to your mind? It is your atrial fibrillation, which is associated with strokes. So if there is a valvular AF, what is the meaning of valvular AF? AF which is associated with mitral stenosis is called as valvular AF. AF associated with any other valve is not a valvular AF. So any other form of atrial fibrillation may be secondary to hypertrophic obstructive cardiomyopathy or secondary to dilated cardiomyopathy, or AF which is associated, like for example, with alcohol consumption. All of these types of AF is not a valvular AF. So the only condition where you call it a valvular AF is because of mitral stenosis. So the treatment for valvular AF is always a warfarin, and for non-valvular AF you can use novel oral anticoagulants like your dabigatran, apixaban. Okay, so for embolic strokes the treatment is anticoagulants. Okay, you do not thrombolize the patient in embolic strokes, you give anticoagulants. Then when do you give dual therapy? That means antiplatelet plus anticoagulant like your dabigatran, because dabigatran should be enough in embolic strokes. Like, so when do you give that? You give that when there is a dual pathology. Dual pathology where? So you have an MI with a embolic stroke. You have an MI with an embolic stroke. So you do have MI and you have to treat the MI. So in these conditions you will give dual antiplatelets. You will give antiplatelets along with your anticoagulant. What is triple therapy? Right? So in patients who have had an ACS, MI and undergone stenting, okay, and they have an embolic stroke, then in these patients you will have to give dual antiplatelets, which is your aspirin plus clopidogrel plus anticoagulation for 1 year, followed by only a dual therapy can be done. Okay, so this is about the various scenarios and how do you manage your embolic stroke. So with this we have understood the management of stroke. Thank you.